So how does Haldane effect influence the oxygen dissociation curve? Haldane's effect, Bohr's effect, again, very, very important. It's not a diagnostic test. Dr. Meenakshi is writing why ferritin. It's a screening test because you want to see the iron stores and you'll definitely know. Okay. So Haldane effect, no idea at all, then Dr. Mandeep, you should have an idea. This is important. Oxygen dissociation curve, and it is something which is not so difficult also. So make sure you please know about this. And to briefly tell you what happens in Bohr's effect is that affinity of oxygen to combine with hemoglobin, it is inversely proportional to the carbon dioxide concentration and to the acidity. So if the carbon dioxide level increases or if acidity it increases, in that case, the affinity of oxygen to combine with hemoglobin it reduces. And when the affinity of oxygen to combine with hemoglobin it increases, the oxygen dissociation curve it shifts to your left hand side. Now in Haldane's effect, what happens is it is opposite of Bohr's effect. So it is related to carbon dioxide. So affinity of deoxygenated hemoglobin to combine with carbon dioxide, it increases. And this will help in releasing the oxygen to the tissues where the oxygen supply is less. And the carbon dioxide which is released in these tissues will combine with hemoglobin, the deoxygenated hemoglobin, because the oxygen has been released. And when this happens, what happens is that the oxygen dissociation curve, it shifts to the right. So when it shifts to the right, what happens is it releases oxygen. Because I told you that when it shifts to the left, oxygen is not released. When it shifts to the right, oxygen is released. Okay. So Bohr's effect basically means that the ability of oxygen to combine with hemoglobin, this is inversely proportional to the concentration of carbon dioxide and to acidity. So if the carbon dioxide increases or if acidity increases, in that case, the affinity of oxygen to combine with hemoglobin, it reduces. Okay. So if acidity increases means the H ions, they reduce. So if H ions, they increase, that means acidity reduces, or carbon dioxide, if it reduces, then the affinity of oxygen to combine with hemoglobin, it increases. So this is very simple. Just remember that ability of oxygen to combine with hemoglobin, this is inversely proportional to carbon dioxide and to acidity. If you remember this, then you can join the dots and you can solve it. Okay. Now, what happens to the oxygen dissociation curve? You know, this is the oxygen dissociation curve. Okay, now this curve, it shifts to the left. If this curve shifts to the left, that means oxygen, it combines very strongly with hemoglobin. The affinity of oxygen to combine with hemoglobin is high affinity. And in these cases, oxygen is not released. Okay. So when the curve it moves to left, in that case, the affinity is high and oxygen is not released. Now, what happens in Haldane's effect? Haldane's effect is opposite. And this refers to the ability of carbon dioxide, the affinity of carbon dioxide to combine with deoxygenated hemoglobin. So if the hemoglobin is deoxygenated means oxygen is released. So that means the affinity of hemoglobin to oxygen is less. And that is why oxygen is released. So if oxygen is released, that means the curve shifts to right. Okay, and what happens in Haldane's effect is this is basically occurring in the tissues, where as a result of metabolism, carbon dioxide is being released and oxygen is deficient. So in these places, what happens is carbon dioxide combines with deoxygenated with hemoglobin, which releases oxygen. So oxygen as a result is delivered to the tissues. So this is what Haldane's effect is about. A 37-year-old lady is examined in the gynecology outpatient clinic and complains of thin grayish vaginal discharge that smells fishy. A sniff test is positive and microscopy reveals presence of clue cells. What is the most likely cause? Again, very simple. Yes, it is Gardnerella vaginalis. Again, make sure because they will have a question either on Candida or Trichomonas or on Gardnerella vaginalis. And it could be a different presentation. So make sure you know about this. A 42-year-old woman gives birth to 2.5 kg baby at full term. The newborn is discovered to have anomalies such as nasal bridge hypoplasia and chondrodysplasia. So which drug is typically associated with such kind of congenital anomalies? And you have to discontinue these drugs. Yes, warfarin. And what do you do if a woman comes on warfarin and she is maybe in her first trimester? What should you do? What should you do if she's on warfarin? Yes, replace it with heparin or low molecular weight heparin, right? A 32-year-old pregnant woman presents with a pruritic rash on her abdomen and thighs. The rash consists of pink raised lesions with central umbilication. She denies any history of allergies or recent medication changes. What is the most likely diagnosis? Yes, it is PUPPP, which is pruritic urticarial papules and plaques of pregnancy. Like I told you, some skin condition will definitely come in your exam. So make sure you know. PUPP is very important. And for PUPP, what you remember is that the rash is there. Unlike in ICP where there was no rash. Here the rash is there. It is associated with severe itching. And the typical distribution of rash is that it involves the abdominal area, but there will be periumbilical sparing. So that is a typical presentation in case of PUP that periumbilical sparing is there, but abdomen is involved. It will also spread on to the breast or to the thighs and maybe to the arms also. But typically the forearms, the legs, the palms, the soles, the face, the mucosal membranes, they will not be involved. So this is a typical feature. It is a relatively benign condition, nothing to really worry about if the woman has PUPP because it'll most likely resolve postnatally or end of pregnancy. And the etiology, it is unknown. Probably it is related to the stretching of skin. Okay, so remember this much for PUPP. PUPPP. Now, if the mother has Marfan syndrome and father does not, what is the likelihood that their child will inherit the syndrome? What kind of inheritance is with Marfan's syndrome? Marfan syndrome is autosomal dominant, right? So if it is autosomal dominant means if the mother has Marfan syndrome, that means even with one chromosome which is abnormal, she'll be able to pass it to her child. So that means 50% of her progeny will have Marfan syndrome. So that means it is 1 in 2 chances. Again, genetics is something which is quite simple because you for sure can answer those questions if you know the concept. Which of the following complications is most commonly associated with sickle cell anemia? Sickle cell anemia can result in sickling crisis. So sickling crisis can precipitate, yes, acute chest syndrome. And that may result in, and that is probably because there's some occlusion which is occurring in the pulmonary vasculature, and this may result in hypoxia and tissue ischemia. And this may result in respiratory failure, and this is a leading cause of morbidity and mortality among women with sickle cell disease. Which of the following is a primary factor that contributes to the development of cholesterol stones in polylithiasis? Okay, so there is a question by Dr. Saida. Welcome back, and I've resumed the session. Fortunately, the pen worked, so before it stops again, I have already drawn this inheritance chart for the autosomal dominant conditions. So now from this, you can see that if mother is suffering from Marfan syndrome, and if father is normal, father would be small a, mother would be, because one gene is abnormal, that means in autosomal dominant condition, it will manifest, the disease will manifest. And her progeny could be either capital A, small a, or it could be both the A's are small. So these two would be normal, and 50% of her progeny would be abnormal, and they will manifest the condition. And this will hold true for any autosomal dominant condition. So you need to know the pedigree chart for autosomal recessive, autosomal dominant, X-linked recessive. Surely, for sure, they will ask one or two questions pertaining to this. See, it is an autosomal dominant inheritance for Marfan syndrome. So that means, so probably the father has a chromosomal pattern, let's say it is small a, and the mother, one of the chromosomes is abnormal, she will manifest the condition because it is an autosomal dominant condition. So you can say mother, the chromosomal configuration is capital A, small a. So obviously she will pass this abnormal chromosome to 50% of her progeny. Out of 4, 2 will be affected. Okay, so we have taken this. Coming to this question. So the primary factor that contributes to development of cholesterol stones in polylithiasis. The main factor is presence of cholesterol. Other factors, elevated bilirubin level, calcium carbonate, they are also contributory, but the main factor which results in development of cholesterol stones is your fatty diet or presence of cholesterol in the bile, which supersaturation of cholesterol in the bile is what results in precipitation of the stones. A 26-year-old nulliparous lady visits a colposcopy facility for an abnormal smear test. A colposcopy biopsy revealed dysplastic alterations indicating cervical intraepithelial neoplasia. Which of the following histological changes is associated with dysplasia? So which of the following is a characteristic feature of dysplasia? Hyperchromatism, because of the increased DNA content. A 25-year-old woman with sickle cell anemia presents to the emergency department with sudden severe abdominal pain, fever, and elevated white blood cell count. After initial stabilization, which of the following is most important next step in her management? So again, this is a question pertaining to sickle cell crisis, but how should you manage her? There's fever, there's elevated white blood cell count, probably there's a potential infection. So you give her IV fluids, broad spectrum antibiotics, and you closely monitor her for complications like worsening, pain, or organ dysfunction. A 32-year-old woman undergoes a complicated cesarean delivery resulting in significant postpartum hemorrhage. After initial stabilization, imaging reveals a suspected uterine rupture extending into the broad ligament. As the attending physician, which of the following is most appropriate initial management strategy? So a rupture extending into broad ligament, that means what should you do? Conservative management probably would not work in such a situation, and you need to undertake Probably the conservative features like conservative surgeries like compression sutures and probably even embolization may not work because it has extended. There's a uterine rupture, it has extended into the broad ligament. So in this case, you have to go ahead with an emergency hysterectomy to save the patient's life. A 16-year-old primiparous lady is spotted. If it is an emergency life-saving procedure, then consent is not. Doctor is by law can undertake a surgery without consent if it is for life-saving purposes. Okay, so that is your answer, Dr. Mandeep. A 16-year-old primiparous lady, okay, is spotted on postnatal ward round 3 days after delivery. She wishes to discuss contraception as her pregnancy was unexpected. She is nursing. What is the most appropriate kind of contraception which should be given to her? Breastfeeding mother. If copper coil is given in this period, it should be either inserted immediately after birth, as soon as placenta delivers, probably within 10 minutes of placental delivery, or otherwise, if it is not done at that time, it should be done after 6 weeks. So in this case, copper coil doesn't work. So what works in this case? Yes, progesterone only pills, right? Sadly, Cerazette is not in the options. Yes, copper coils and copper T are same, Dr. Ruby. But in this case, this will not work. Okay. So let's come to the next question. Okay, so a 35-year-old woman presents with irregular menstrual cycles, fatigue, and hair loss. On examination, she has a thinning scalp hair and a palpable thyroid nodule. Which of the following investigations in these cases would be most appropriate? Yes, this points to probably hypothyroidism. And usually irregular menstrual cycles, they could be associated with abnormalities in thyroid hormone levels. And if you measure TSH, if it is low, if TSH is high, it means it is hypothyroidism. And if it is low, it means probably it is hyperthyroidism. A 24-year-old nulliparous woman A 24-year-old nulliparous woman presents with cyclical pelvic pain and dysmenorrhea. On pelvic examination, there is tender retroverted uterus with multiple tender nodules palpable in the cul-de-sac. So what is the most likely diagnosis in this case? Yes, typical endometriosis features. Presents with postmenopausal bleeding. Pelvic ultrasound shows a thickened endometrium. Which of the following is most appropriate next step in management? So what should you do? And how much should be the endometrial thickness? Yes, an endometrial biopsy is what is required. And probably that you can very well even manage through endometrial aspiration. And yes, everybody is correct. It should, the benchmark is 4 millimeters. It should be less than 4 millimeters, the endometrial thickness. And if you encounter that endometrial aspiration is abnormal, probably then you can go ahead with a hysteroscopic guided biopsy. A 22-year-old nulliparous woman presents with primary infertility. Her menstrual cycles are regular. Which of the following is most appropriate initial investigation? So in case the menstrual cycles are regular, that means she is ovulating and ovaries are probably functioning properly. So what should be the next step? What should you do in this case? You should do a hysterosalpingogram to check her tubes. Because if the ovulation is occurring, probably the defect is the tubes. Again, just note they haven't mentioned anything about the semen analysis in this case. So if they don't mention something, then probably, and it's not in the options also, that means it's probably normal. A 30-year-old woman presents with recurrent episodes of pelvic pain, dyspareunia, and dysgeusia. On pelvic examination, there is tenderness in the pouch of Douglas. So what is the most likely diagnosis? Again, very simple. Yes, endometriosis, dysgeusia, dyspareunia, cyclical pain, tenderness in the POD. A 28-year-old woman presents with heavy menstrual bleeding and iron deficiency anemia. Pelvic ultrasound reveals a 10 centimeter submucosal fibroid, distorting the uterine cavity. So which is the most appropriate management in this case? Yes, mammectomy is the best option in this case, no? She is 28-year-old. You need to retain her uterus also. Probably her family probably is still not completed. They don't mention it. But then the HMB is affecting her iron levels. So obviously this has to be treated and the best option would be myomectomy. A 30-year-old woman presents with recurrent episodes of breast pain and swelling that worsen before menstruation and improve afterwards. On examination, there are no palpable breast masses. Which of the following is most likely diagnosis? So breast pain and swelling worsening before menstruation and improving afterwards. What's the most likely cause? Yes, the fibrocystic diseases. And you reassure such women. Such women, they normally come a lot in the OPD complaining that they have a breast lump. But this is absolutely normal because this will subside with her periods. A 30-year-old woman arrives at the early pregnancy unit with mild vaginal bleeding. Following an ultrasound, diagnosis of complete molar pregnancy is made. What are the parental origin and genetic characteristics of this complete molar pregnancy? So what is the genetic constitution in a molar pregnancy? And what happens in a molar pregnancy or what happens in a complete molar pregnancy? Yes, what is happening in a complete mole, I'll explain you. So this is what is happening in a complete molar pregnancy. Complete mole basically, the all the chromosomal constituents are derived from the father. So it is just the paternal chromosomes which are present, and that is why such an abnormality occurs in cases of complete moles. So what happens is, you can see here, the first picture shows what happens in a normal person. A normal person, the sperm will have its 23 chromosomes and the ovum will have its 23 chromosomes, and the combination would result in 46 chromosomes. But what happens in cases of a complete mole is the maternal chromosomes are lost. So this ovum, it becomes empty. And there can be two situations in this case. Either the same sperm, the genetic matter, it duplicates and it results in formation of 46 chromosomes, or there could be two sperms which are fertilizing the empty ovum, and this may result in just the paternal chromosomes being there in the uh, embryo or the zygote. And usually this is 46XX. This also comes as a question that what could be the constitutional composition of such gestation, the complete molar gestation. In an incomplete mole, on the other hand, what happens is the constitution is basically 69 chromosomes. So maternal chromosomal counterpart is not lost. But at the same time, the sperms, the parental composition, it gets doubled up. So you can see here that the paternal composition has doubled up and the maternal composition is just single. So this is a total of 69 and this is 69XXY. So this could also be a question in itself. And for sure, you'll get one or two questions pertaining to molar gestation. So again, make sure you know them. So now coming back to the question, now I think you'll understand that she arrives in the early pregnancy unit and what are the parental origin and genetic characteristics of this complete molar pregnancy. So there are two paternal sets. It is diploid. It's not haploid, but both the sets, instead of one set being from the mother and other set being from father, both the sets are from the paternal side. So it is two paternal sets and diploid. So a 22-year-old Asian woman is hospitalized due to an incomplete miscarriage at 11 weeks gestation. Following surgical evacuation of the uterus, the histological examination reveals focal hydropic placental villi alongside normal villi and fetal tissue. So what is the most probable karyotype and parental composition? So what is the molar gestation we are talking about in this case? Yes, we are talking about incomplete mole, and so it is 69XX5, which is paternal and maternal. I just showed you how it is. So now coming to the next question. A 20-year-old woman presents to the gynecology clinic complaining of pelvic pain. Following evacuation, she is scheduled for diagnostic laparoscopy. Being nulliparous with a BMI of 20, she is at risk of injury to which of the following blood vessels during the procedure? So, minded that her BMI is 20, so she is a very thin patient. So, in such a case, which blood vessel is most likely to get injured? Yes, the abdominal aorta. If you insert the trocar with too much force, it can probably hit the abdominal aorta, which can be even fatal in this case. A 55-year-old woman presents to the gynecology clinic with a history of vulval intraepithelial neoplasia. Upon evaluation, it is determined that the lesion is confined to the small area of vulva. Considering the patient's age, overall health, and desire to preserve as much vulval tissue as possible, which treatment option would not be appropriate for her condition? Again, read the question very carefully, not appropriate. The question could have also asked which treatment option would be most appropriate. Now, in this case, which is not appropriate for her condition? It is just a VIN. So, what is something which you will not do in case of VIN? Obviously, a radical vulvectomy, because that will involve removal of major amount of tissues, lymph nodes, both the vulvas, adjacent areas. So, for a VIN, all that is not required. A 29-year-old Caucasian woman visited her general practitioner at 37 weeks into her pregnancy after developing a chickenpox rash during the winter season. She was prescribed oral acyclovir for a week and advised to return if her condition worsened. However, 3 days later, she presented to the emergency department experiencing severe shortness of breath. What is the likely diagnosis? So she probably has varicella zoster induced pneumonia. And this is one of the major reasons why you should be very, very careful with varicella zoster during pregnancy, because this may result in pneumonia, which can result in significant mortality or morbidity for the women. 18-year-old woman presents at the gynecology clinic with complaints of urinary incontinence occurring 3 months after experiencing a third-degree perineal tear during a routine vaginal delivery. Which muscle comprises the levator ani muscle? Which muscle primarily comprises the levator ani muscle? So levator ani, you know, is composed of three components, but which one is the major component? Pubococcygeus. Obviously, pubococcygeus is the major component of the levator ani. So see, you can see this is levator ani. This is the pubococcygeus. This part is pubococcygeus, and it also forms puborectalis, or the sling which surrounds the vagina and the rectum. And there is a little part of it which is also ischiococcygis. This is the small part. And there is ischiococcygis and there is also ileococcygis. Ileococcygis is this part. So the significant part is tubercoccygis.